Hey, hello and welcome to Catalyst for Healing. My name is Dr. Yanuck. I'm with Maria Lloyd here. Today's podcast, we are going to be talking about who is a good candidate for ketamine. It's obviously kind of an important question in this space. And so I think what we're going to do to go through this is walk through kind of the steps that we each personally take when we're evaluating someone for ketamine. And then at the end, if we have some time, we're going to go through some questions that we've gotten from people to discuss at the end, which are kind of exciting. Okay, so first off, when someone comes to you and you're thinking about maybe ketamine for them, what are the first questions you are asking them or asking yourself in your head when you're making that decision?
Well, I know we talked a little bit about this with the modalities episode, but for me, it's always about the question of, what is adding that dissociative element going to add to the trauma work that we're already doing. So generally, in my opinion, a lot of mental illness is trauma based, and if we can get in and resolve those traumas, the mental illness will improve. So whether it be depression, anxiety, all of the diagnostic labels we have, which by the way, nobody fits perfectly into any category. If it's trauma-based, we're gonna do that work first. And if I'm hitting a roadblock, I'm not making progress, that's when I would consider, approaching ketamine as an option.
Yeah, so I think when patients are reaching out to our clinic, they usually come to us in a couple of ways. One is self-referral. They have someone they know that's gone through it, a physician's referred them, a therapist has referred them, and those people tend to have some inkling of what ketamine is. And then we have some people who maybe a family member has said, hey, I think you should reach out to them, and they'll make the appointment for them. But for the most part, when people come to us, they have a very rudimentary idea of what ketamine is. And so for the intake process for us, the first thing I like to do is briefly get to know the person. And then I go through a series of questions determining from a medical perspective who is a good candidate. And so I think I'm going to go to that first. It's kind of the most boring part of it. But
is there a certain trend in terms of what do you notice the majority of people are coming to the clinic for?
I mean, it's depression, anxiety, PTSD.
Okay.
For sure, that's the vast majority of our patients, which turns out there's a ton of people with those conditions that are not getting better with other modalities, right? The predominant literature shows that for the traditional antidepressants, for example, they work for about 40% of people. But even with those 40% of people, sometimes they work, but then they have undesirable side effects, right?
A lot of undesirable side effects. And like you had said, they take 4 to 6 weeks to work, but a lot of people will be on them long term, and there's other complications that come from that. But the medication might work for a little bit, and then they might have to increase the dose, and then they might have to switch medication. They don't really know why. Do you know much about that? In terms from a brain, they don't really understand why that is.
Yes. The mind is very complex. Let's just put it that way. But yes, there is something to the pharmacology of switching medications and then starting the same medicine over, and all of a sudden it's starting to work. But when patients come to us, the first step that I kind of go through is making sure that they are medically safe for it. And I run through a series of questions, of which I can go briefly over kind of the big hitters. There are certain things that we call absolute contraindications, where if you have this, no. Because at the end of the day, my job as a physician, your job as a therapist is do no harm, right? I don't, this is, at the end of the day, this is elective, as are most things in this kind of space, and we want to make sure that you're safe to do it. So number one is if you have a history of seizures or epilepsy. Obviously, it's pretty rare, but if you have it, there is some evidence that ketamine can lower your seizure threshold. All of these absolute contraindications, I think as we go on, we're starting to see are more relative contraindications, and I feel deeply that for a lot of these patients that are excluded from these things, a lot of it, the undercurrent is because we think mental health issues aren't as significant as other medical issues, right? I think we can have an informed conversation with the patient about the theoretical risks of maybe slightly increasing your seizure threshold. But unfortunately, when it comes to the current framework we're at right now, medical malpractice and things like that, we ultimately have to make the decision with where we are in our current framework.
Yeah.
If you can kind of read between the lines there. So seizures, out. If you have a history of drug-induced seizures, for example, like alcohol withdrawal seizures or things like that, that's different. That's not the same as having like organic, like, you know, epilepsy or something that you're on medications for. Okay, so that category.
Could you address that real quick?
Yeah.
Because
so
if you have someone with a severe addiction, you might have to have them wean. We just had a situation.
Yeah, so if you're, for example, if you are, you know, there are certain drugs that you can stop cold turkey and it's safe to do. It's miserable, but it's safe to do. Things like smoking, opioids. But there are other drugs, like if you're abusing benzos, like Ketamine or Xanax or alcohol, act on the same receptors, that if you're a chronic user and a high user, if you stop cold turkey, I mean, it could be fatal.
Yeah.
You can get seizures, delirium tremens, things like that. So in the ER, I mean, all the time. I would say at least once a shift, I see a patient that is usually going through some sort of withdrawal. I think it is interesting that it is becoming less and less common. That's a whole other story, but it is something that is dangerous and needs to be done under medical supervision. But if you've had a seizure from an alcohol withdrawal in the past, that doesn't preclude you from getting ketamine therapy, assuming that you have safely withdrawn from the alcohol, meaning you've gone through that kind of detox period under medical supervision, and now you are out of that window, which is typically about 72 hours after your last drink, typically. Okay, that's seizures. Another bucket is if you have a history of psychosis or schizophrenia.
And bipolar.
You're going to
address.
Oof, yeah, okay. All right, we're going to do bipolar. Bipolar is just tricky because I think bipolar is a simple word for a big bucket of people. Right?
Yeah. So to clarify this one, I think what we're finding, and there's not research on this, but it's just where therapists are kind of starting to see is a lot of the bipolar 2s are sometimes trauma-based. So it's not really, I think it's safe to do, it's safe to do when they're in a depressed state, but not in a hypomanic or manic state. Is that correct?
Yeah, I think
okay.
Caveat, I'm not a psychiatrist, Maria's not a psychiatrist, but we're able to we understand these different diagnoses, but we aren't formally making these diagnoses. Yeah. With that said, if someone has had a history of a psychotic episode that's not drug-induced, a history of schizophrenia, which most people are at least aware of, or auditory hallucinations, visual hallucinations, things like that, or a manic state. Manic, it's
if
not.
They've had a manic episode with psychotic features.
Yeah, manic is not I worked through the night and I was so focused on my work. No, manic is you're up for. I mean, there's DSM, there's specific criteria for it, but I think most people understand what I'm talking about. Manic is not just I was focused for a couple of days and revved up. No. So if you have those features of psychosis, schizophrenia, had manic episodes in the past,
right.
It would almost always be an absolute contraindication because there is a risk that with any psychedelic S medication, ketamine included, it could precipitate an event like that. With that said, there are some patients, we haven't had any through our clinic. No, we haven't had any through our clinic, but there is some literature, some case reports that for patients that are well controlled on a current set of antipsychotic medications that are under close supervision of a psychiatrist and a supportive network of family and then a therapist, things like that, that if they are having predominantly depressive features, that ketamine could be safe in that environment.
Yeah.
We're not going to get into that now. For now, let's just say in that bucket, unless for very specific situations, it's going to be excluded.
Right.
Other absolute ones that,
Which, speaking of, because this might be a question people have, you don't need to get off any medications that you're on in order to do ketamine.
Yeah.
There are certain medications that might affect the dissociative part a little bit more, and so you might minimize them.
Right.
So that's a very tricky process, but we don't recommend people get off their medications to do it because that takes a long time and it's a delicate process and it's not necessary. But when we move on to MDMA, which is getting legalized, probably the next psychedelic to get legalized, that is a substance where you would have to get off your medications completely.
Certain ones, yes, for sure.
Anyway, that's just one thing I wanted to throw in.
Yeah, no, that's a good point. Okay, and so those are the big absolute contraindications. If you have a history of severe cardiovascular disease, multiple strokes, stents, uncontrolled high blood pressure, cardiac arrhythmias like atrial fibrillation, atrial flutter, ventricular tachycardia, and all of which is poorly controlled, contraindication. Now, we've had patients that have had pretty severe cardiac disease, however, they are being closely managed by a cardiologist, they've been stable for more than 3 years, have not had, acute events.
Right.
And for those patients, we're able to have an informed discussion with them to see if they would be a candidate for it. And it's always a cost-benefit analysis to the patient, right? And so a hypothetical, for example, and really the way that ketamine works from a cardiovascular perspective is it works on a part of the nervous system, let's say, called the sympathetic. It's a fight or flight.
Yeah.
And so it will rev up your heart rate, rev up your blood pressure transiently, but it will, meaningfully.
Yeah.
So if I have someone that has a history of cardiac disease, but then is also concurrently working out 20, 30 minutes a day on a treadmill and not having issues and stable for 3 years with no disease, that's no different than getting a ketamine infusion in my mind, because at the end of the day, that's stimulating the same sympathetic system, the heart rate's going up, and clearly their heart is able to handle it.
Okay.
Now, of course, I can never guarantee that there's not a risk that it could precipitate a cardiac event, but I think this is case reportable, meaning this is an extremely small and rare group of people that have had these events happen. But it is something that we monitor for. So for example, if you were to come into the clinic and your blood pressure were to be 200 over 110, we wouldn't proceed with the ketamine therapy because we know for sure your blood pressure is going to go up with ketamine therapy. Yeah. The top number is going to go up by about 25 and the bottom number is going to go up by about 10, 15, every patient, right? And so what we do with that number is use it to basically screen you out in the moment if we can't calm you down. Yeah. But actually in the experience itself, while we might keep an eye on it, it is not necessarily something that guides our treatment. It depends on the numbers, right? But
do you find that's the most common problem, people coming in not knowing they have high blood pressure?
For sure. Okay. We've diagnosed hypertension on many people. Now, I should say we've diagnosed it. We've alerted them that the blood pressure is high. When you come into a ketamine clinic for the first time, even if it is the calmest, safest space, you're going to be nervous, right? Because you know it's going to be an intense experience. Yeah. So everyone's blood pressure is high when they come in. But usually we're able to kind of like breathe it down, calm them down, and we lie them down for a little bit, eye mask on, get the blood pressure again, and see what is really going on. And most people's goes down. But we have had a couple of people that we've had to turn away that have come to the clinic that we just couldn't get their blood pressure down without giving a medication, which we don't want to do in the moment.
Right. And then you have to have them manage that before they're able to start the treatments.
Right. So that's kind of the cardiovascular bucket, if you will. It's not absolute, but you basically, it needs to be very stable, and you need to get the clearance from your cardiologist or have a really close team that's following you and show that things are stable and not getting worse. Yeah. Because as a side note, and not to digress too much, we know that there is real cardiovascular side effects to chronic stress states like depression and anxiety. Yes. And as much as we feel like this is elective, and I even said it earlier, like there is a real detrimental effect to living in these states.
Right.
And so like I think one could argue for some individuals that are stable cardiovascularly, living with severe depression is possibly worse for them than the slight risk of getting a medication that could potentially help their symptoms. Anyway.
That's a great point. Yeah.
That's kind of how I feel about it. But we have these discussions, both me and the patient, me and you as a therapist, and things like that. And Maria is going to chime in here when it gets to the therapy side of things, I promise. So that's a cardiovascular bucket. Then there's other things. There are certain medications rarely taken that in theory when combined can be dangerous, things like aminophylline. I can't even think the last time I saw a patient on that. If you have glaucoma, like in theory ketamine can increase the intraocular pressure, mixed evidence for that, but if you have uncontrolled glaucoma, thyroid disease that's uncontrolled, the basic thing is uncontrolled anything.
Okay.
I think we want, at most part, the medical stuff to be plateaued, stable. But if it's relatively controlled, we can work with that. Severe kidney disease or liver disease, because the ketamine is processed through these things, it would just be something we would need to know and would need to possibly dose accordingly. Yeah. There has been some evidence that really high doses of ketamine over a long period of time, like in patients over days, can increase in liver function tests. And so if someone's got a history of severe liver disease, it's something that we would want to know what their last values were and possibly follow that if we were to be doing really high doses, but it's not that common. those are like the big clinical things that we talk about. I'm sure I'm going to think about more, but those are when I'm walking through a patient, kind of like big branch points. Before we get into like why you're talking to me, I just want to make sure, are you even able to do this?
Yeah.
Maybe from a therapy standpoint, let's pivot to you for a sec to let you go.
Yeah.
How do you determine if someone is ready or the right candidate to undergo ketamine treatment or not?
Well, again, I always meet with them first. I find out their goals and determine whether that's something we would work towards. It's not something I jump into with people at all. And the other big thing that we get both at the clinic and in my office is people want a quick fix, and we understand that. That's our society is kind of geared towards quick fixes, but as we know, nothing really is a quick fix. And so I always have to explain that to people because they hear, oh, ketamine, this is the new fix. Again, why we intentionally called this the catalyst for healing, not this is your healing, because it's
not the silver bullet.
It's not a
podcast.
silver bullet. And so I try to explain, like, this is something we would add in, again, if they're not able to do the trauma work with these other modalities.
Sure.
And that's kind of where I make that determination.
Yeah.
And if they're on the more moderate to severe, I mean, you know, I can't help them with talk therapy if they're having thoughts of harming themselves every day. That's when I'm like, this is IB is for you, right? Let's get the medicine to get you out of that state.
Yeah. Yeah, I think it's interesting when it comes, because we really have, I think in an ideal world in this space, the doctor and therapist really come together and both should have an equal say in whether they feel like the patient is ready for this. And the patient as well, right? It really is, I mean, there are multiple arms in this, obviously. But assuming
we're not there yet, it's because the clinic's rolled out through doctors like yourself, and then therapists were learning the modality with the sublingual. And so I think we haven't quite gotten there yet, but ideally clinics would have therapists on site and they would be combined, and psychiatrists hopefully will start getting trained.
Absolutely.
We know some are getting trained, but that's another element that's really important because most of these clients are on medication as well.
Right, yeah.
And so right now there's a bit of chaos in that it's a very disconnected process and nobody quite knows, you know, how to bring those together. But
it's very emblematic of the U.S. healthcare system as a whole.
Yeah,
Exactly. It's just like there's so many cooks in the kitchen. But at the end of the day, I think the core components are the administrator of the medication, the therapist, and you, the patient.
Yeah. And finding a clinic that you trust, you know, that you feel good about. Finding a therapist that you trust and feel good about.
Right.
And those exist all over. It's just you might need to interview a few places. And
so other questions, you know, when it comes to like the who was the candidate, you know, I went through maybe the medical exclusions, but obviously from a psychiatric perspective, while I have kind of some philosophical belief about psychedelics as a whole and humanity as a whole, at the end of the day, I am treating people that have real disease. Right, and so I have to make sure that we are focused on those patients that have real diagnosed disease. And I think for patients that come to me with, I'm a little bit depressed, maybe some days I'm having a hard time waking up or just getting joy out of life. I haven't tried medicine, I haven't tried therapy. Like, as much as ketamine could help those people, like, it's definitely not the right first route, right? You should go through other steps, which are very likely to help you, be much cheaper.
Yeah.
And
try everything, I say. You know.
And hopefully, you know, avoid the having to kind of commit to coming into a clinic or something like that and getting this medicine. And you know, like the ketamine process, while it can be really beautiful and powerful, it's
because again, people wanting the quick fix, it's getting the medicine, but if they're not doing the work, the illness is going to resurface. So whether it's depression or anxiety, we're not seeing longitudinally that this is lasting unless the trauma work's resolved, right?
Yeah. So, I think kind of the severity of the disease is one part. Having some formalized diagnosed disease, right? I think is helpful. I think not helpful. It's required. Our patients oftentimes are either diagnosed by a psychiatrist or their primary care doctor with their disease.
So it's people where nothing is working, is what I'm finding. And I mean, I work with more severe cases with depression, with anxiety, I mean, these people have tried everything. I've been working with them perhaps for years. Nothing's working, you know, and those are the people that are the right candidate for, especially the IV.
Right.
It's like, I'm not hesitant to say this is something that really could help you.
Right. Yeah, I mean, the medical term for it is treatment refractory.
Yeah.
Like, you should have tried something, and hopefully, you know, if those things work, great, and if not, then this is something that can help those people that have tried and failed other things. Mm-hmm. Maybe there will be a day where something like this, psychedelics, can become first line, but we are not there yet. The literature is not there yet, and we are definitely not there societally, and that's okay, from the medical establishment as well.
But we are seeing there's an incredible movement in that direction because of the efficacy.
Yeah.
The fact that ketamine is 80% effective compared to antidepressants is pretty significant. Yeah. Clinically.
Yes. Yeah. Sorry. We obviously we have feelings here, but we're trying to like keep it professional too. For sure. Okay. So oftentimes then after I do kind of like the medical questions and the patients kind of walk me through their diagnoses and who they've seen and the medicines that they're on, the next step that I do to kind of assess if they're the right fit for the patient, or right fit for the clinic is like, what is their home life like, right? And I think it's an important consideration. We're not a retreat in Costa Rica where you get to relax for 2 weeks and be on your own and not deal with the real world. Most of our patients are coming from the real world, right? And so like if you're in the midst of, I don't know, like you're about to have a really important trial, you're a lawyer and you have a trial in 5 days and you want to start now, obviously not the right fit. Or if you're really chaotic at home and there's just no way that you can get help for anyone to take care of your kids for maybe a half day or so and things like that, like I don't think it's the right time. If you're going to invest the money in this, the energy, the time to do this, you all these variables need to be optimized. If medically things are dynamic for you, not the right time. Right?
I always say find a peaceful time in your life where there's not
to the best of your ability.
To the best of your ability. I mean, people aren't taking off work, but they're making sure maybe those couple of weeks they're not adding the extra things in their schedule so they can have more downtime. And their weekends are really relaxing because I mean you do need space in order for the medicine to get the most benefit from it. Yeah,
I think for most of our patients we recommend for the first infusion, definitely that day after the infusion have nothing planned.
Yes.
Nothing, like not a dinner with my husband in 5 hours, not like truly nothing. Really give yourself the space to be present with no noise, not like auditory noise, but just any distraction, so you can just process what you just went through, and then ideally the next day.
And don't get back on your phone.
That's
the other thing. Try to like not have devices. This is a really critical time to utilize journaling and meditation and relaxing activities or nature. Because all of the insights, you're really, going deep with the process.
Right. And then usually the day after the first one, we try and say, try not to have too many responsibilities that day. It's not like you're not gonna, the next day, it's not like you're not gonna be able to like do basic activities. You can. We have people that go work the next day. But I think in an ideal world, you would have that next day off just to see how you respond to it. Make sure that you're not one of the people that just the next day, they just want to sleep all day. Because that does happen.
Especially the first.
For sure.
The first.
So I think that's just an important consideration. But at the end of the day, I also think there is value in doing a ketamine treatment protocol in your real life. Because I think at the end, going on a vacation retreat, doing the ketamine and then coming home to your real life, they're totally different worlds.
It's true.
And I think having the neuroplasticity of ketamine while you're interacting with the stimuli that might trigger you one way or the other, there's real value there. Maybe you can speak to that, maybe your experience with some patients. Have you noticed that at all? Like,
I mean, that's a really good point. I hadn't thought about that. But I mean, I could see the benefit of doing it in a retreat setting only because you're really, having the space that you need. But at the same time, to your point, you're coming back to real life, and then how do you integrate all that? So while you're doing it in your daily life, you're just slowing down your daily life. But it's also because a lot of the processing and the things that we talk about with patients after their treatments are there environments that you're in or relationships that you're in that are causing some of these symptoms. If you are in a toxic environment at work or with a partner and you know, you start to notice with these ketamine treatments that you're feeling better, but when you go right back to that experience and you're feeling bad again, it's like we need to make some considerations about possible changes, because a lot of times that is, you know, a big factor.
Yeah. So I think that's kind of like the home life bucket of patients, right? I want to make sure that there's some stability in your home life to the best of your ability. Right. And obviously it's a two-way street. We're kind of optimizing that, but I think if possible, the more optimized and the more you can devote to kind of really being present with yourself, the better.
Yeah. But most people are living their lives. They're going to work.
The
next day they'd feel fine. So this medicine really, I mean, if you did it in the afternoon, let's say, you know, the evening off, by a couple hours after, you're going to feel okay, but we just don't want you to jump into, even though you could.
Yeah, right. And I think just acknowledging everyone responds differently, and making sure that you have some protected time after each one, depending on how you respond. And each infusion might be different too. Okay, so that's kind of the home life variable that we think about. Yeah. And then we also have the variable of the medical complications or medical issues and things like that. And then we have the last one, which I think is, you know, it's the elephant in the room, is like the financial barrier.
Yes.
Right? It's expensive.
Yeah.
Like, let's just say what it is, right? Like, this is an expensive therapy. And I think in an ideal world, we wouldn't have that in between the doctor-patient relationship. But like, we live in the United States, we practice this in the United States, and unfortunately, I mean, I think this is true of most of the world right now, this type of therapy is not covered by insurance, and therefore you are working directly with the clinical office and having to pay us rather than the insurance paying us. Yeah. And then there's some artificial costs that are inflated for us as providers in this space, right? We're working in a space that, while legal, there are a lot more protections and safeguards we have to institute for ourselves to make sure that we are covered as well. Yeah. Right?
And so get a whole different medical malpractice insurance that covered cap. I mean, there is, because again, you know, lawsuits could be more.
Yeah.
I don't
try and beat around the bush with this, and I try and be I am transparent with the patients. Like, our price is on the website. Yeah. Period. Right? And I think I don't ever want a patient to feel like, oh, you said you were a lawyer? Oh, we could probably charge them a little bit more. Or you said this. Like, I just want, like, this is our price. And I'm probably maybe more in tune with it in general, just because I feel this internal tension with it, right? Yeah. But at the end of the day, like, I have made this my profession. I have staff. Right. We've worked really hard to build something like this, as have you. And like, I think there needs to be some consideration for the intrinsic cost of running something like this, but also for, like, this is our work. Like, we're not doing other work while we're doing this. Yeah. And then to see if it's right for you. Like, I don't think it's right for a patient to go bankrupt for this. Like, unfortunately, like, as much
that's causing another problem. That's going to cause stress, and then that's going to cause mental or physical health
and so
issues.
I think it's totally valid, and patients oftentimes will lead with this. Ask upfront, like, what is the cost? Yeah. Because I think, like, there's no reason wasting your time with a 30-40 minute consultation, which almost all clinics do for free, as they I think should. Yeah. I have strong feelings about that, but anyway, that you should be able to ask them what the cost is, and they should be able to answer you immediately. It shouldn't be like, well, depending on this or that. Like, it should be, if you are doing it for this purpose, it's this. If you're doing it for this purpose, it's this. And that is solely based off of the time in clinic and dose, and that's the only variable for cost.
Well, and I think, I mean, because people think this with therapists and with ketamine clinics, oh, they're making so much money. They don't really understand how, like, much training goes into it, how our leases and our office spaces. For instance, California, the cost for doing ketamine therapy are much higher than other states in the country, just because our rent is so expensive. Yeah. And so there's so many variables that it's not like these clinics are trying to rip you off and make a bunch of money. They're trying to do the work that they do really well. I mean, you guys have staff, like nurses that you're paying, and you've got overhead, you know, and all of that stuff. So that is just something that I hear people say, and I'm like, I hate that there's that perspective, but it's really not the reality for those of us in the field. It's not like we're ripping people off trying to make a bunch of money off of this.
I think
it's a very expensive thing to do for many reasons.
No, I agree with you. I think patients are right to be aware of it. I think medicine as a whole, there are some doctors that definitely, maybe predatory is too strong of a word, but definitely make a lot of money doing what they do.
Yeah.
And I think it's not that they're doing it necessarily for nefarious purpose or not helping the patient, but they make a lot of money doing it. But I am like always very cognizant of the fact that this costs money. And so I think as long as you have an open discussion with the doctor or whoever you're speaking with.
And most people have it on their websites, I think, from what I've seen.
I actually don't.
Oh,
that's
really?
Actually in my...
Okay.
I don't think it's true. I don't know. Maybe I'm wrong. I think they should. I think they should publicize it. But I think there's a lot of clinics that don't. I don't know. Maybe you guys can let us know what you think. I think on the whole, though, a lot of clinics don't publicize
in general, can you give an idea of what a range is that people can expect?
Like
in California.
No, that's fair. No, I mean, I think I could probably speak to like the country as a whole. I would say it probably ranges, the numbers I see between probably 500 would be on the low end. This is for an IV infusion in like a monitored setting per infusion. 500 on the low end. Yeah. The highest I've seen is about 900 on the top end.
Okay.
And that's usually for a 40-minute infusion in the office for probably about 2 hours or so. Yeah. And that should be with, a provider monitoring you, a nurse with the IV and all that kind of stuff.
Yeah.
That's my range. Would you agree with that? And what about?
So then that for 6 sessions, that'd be
$4,000 to $5,000.
Yeah, $4,000 to $5,000.
$3,000 to $5,000.
Okay.
Insurance, depending on your deductible, with the super bill reimbursements, should give you.
But you'd have to have a PPO in order to use insurance at all. The other piece is you can use a health equity plan. So if your company has a health spending account, HSA, or Flex, I don't know.
FSA,
I said that right.
HSA,
HSA, you can use that because it is medical.
Yeah, that's true. And we have had some patients use those cards, and I think that's great.
And we've explained in the modalities piece why the IV might be more beneficial than other routes. But that's, that's why also that you want to consider that when you're comparing to maybe the free route of the intranasal, which is, if that's all you can do, that's great, and do it.
Absolutely.
But that's, again, just part of that consideration.
Absolutely. Yeah. And then, the other thing that I think is worth asking clinics is do they at least provide super bills? And super bills are things like, most people are familiar with it if they work with therapists. But basically, it's a bill that you give to the patient that they can then submit to their insurance as like an out-of-network claim that they then can get reimbursed for. And there are third-party apps like you talked about, Reimbursify and things like that, which is like, navigating this complex healthcare space is insane. Anything to lubricate this process.
Right, to help clients get their benefits back, because a lot of people with PPOs don't quite understand how to get their reimbursement, so they don't ever submit anything. So I try to help with that a little bit.
Okay, so I think
let's move on. Yeah.
we have I've done 3 buckets, and I have a bucket that I'm going to give for you. So we have our medical bucket, we've talked about, we have our home life bucket, we've had our cost bucket. And I think honestly all of those are important to discuss equally, and I try and devote time for each one during the initial evaluation. The last bucket is, and we've discussed this a bit already, but I just, if you have anything to add, is the therapy side of things, the actual, are you ready for the experience?
Yes.
Right? We have had patients that you have very much been like, I need a couple beats with them. Like, maybe let me work with them a bit. And then they can come back to you. Something like that. Maybe if you have any thoughts on that.
Yeah. One of the things I think we talked about in our previous episode is, one, if they're anxious and resistant, it's very difficult to get the most benefit out of treatment. So sometimes it's kind of helping people understand. I try to go into detail of what they're going to experience because that just brings down the anxiety and, enough where they're like, okay, I can go in and do this. And I try to explain that it's generally this peaceful 40-minute dissociation. It's really not that scary thing because people are mostly afraid of something bad coming up. And you guys start with the lower dose at the beginning so that it's not going to happen, at least in the first session, rarely, or has it?
It has, but it's just hard to predict. Honestly, I think you're right on the whole. And when we say lower, we start with the standard dose, which is pretty uniformly standard of care is 0.5 milligrams of ketamine per kilogram of body weight.
Okay.
Over 40 minutes. That's probably 95% of clinics do that to start.
Yeah.
But go ahead, sorry.
So anyway, I think the anxious clients sometimes aren't ready because they're not going to be able to surrender into the experience.
Right.
And so I'll also work on maybe some breath work or meditation with them, and that can give them some tools to use at the office so that they can be in a calm place going in. I would say those are the biggest ones. I think, we just have to work with the fear. Like, a lot of people, of course, have a fear of something bad happening.
Mm-hmm.
And so we have to do more education, a little bit more. That's kind of just a little bit more of understanding what they're afraid of. Sometimes that's connected to trauma work that needs to get addressed. Mm-hmm. So I think those are the main situations we've had.
Yeah, I think that summarizes it pretty well. And I think it's one of those things too, maybe it's hard to explain it, but I think you just have, working in the space for as long as you have, I think you just have, as do I now at this point, just a gut instinct of like, yes or no, they're ready or not.
A lot of it's intuition. I do have those patients that think this is the silver bullet, and I want to work with them sometimes a little more to make sure they know this is just the start of probably a lot of work that you still need to do on yourself. And so that comes up too. But you're right, a lot of it's instinctual just because I've been working in the field for a while.
It's so hard. It's such a balance. I have a hard time with this as a provider of finding the balance between giving patients hope but also being realistic with expectations. Mm-hmm. I don't know if I've figured out the best way to do it, to be honest, other than to try and just walk them through what the evidence shows and what my experience has been. And I don't try ever to deliberately mislead patients that way. And I think as long as I give patients the information that is factual up until what we have right now, ultimately at least they can feel informed to make the decision that's best for them. Yeah, I was
just thinking of a recent patient that thought this was going to be an easy process, and it's really not, because you have to do a consult, and then you think of all you have to prepare for this treatment, and then the sessions with the therapist, and so they got very upset and said, I thought this was going to be quick and easy, and I had to say, I don't know, I never said that, first of all, but also it is hard work, and so if you're not prepared to do the hard work of just commitment to the process and the hard work of doing the integration stuff with the therapy, then don't do it, is what kind of where I'm at, because I don't want patients to go in thinking this is a cure, this is a quick fix. All of that stuff is setting them up for disappointment, first of all. But second of all, there's a lot of hard work that comes with all of it, and I think there needs to be that acceptance of that before going in.
Yeah. Okay, well, I think that kind of summarizes the big buckets of things that we think about when we're doing a consult with a patient. And then oftentimes, the patients will obviously open up about their personal history, their, all their traumas, things like that. And then we'll have a lot of questions for us. And I think we're already a little bit long. We'll probably hold off on a lot of the questions that we get for another podcast. We have so many questions that are common ones that we get. But I think this is a good summary of what we think about, main things that are contraindications, main things that are relative contraindications. And I think all of it comes down to each party feeling like safe and ready to commit to this process.
Yes, the readiness. That's what I was going to say.
All right. Well,
all right.
That's it. Thanks for listening and watching. We'll see you next time.
Thanks. Bye.